So timing wise, it's my introduction. I'm just going to give a very high level overview of where the pioneers and Neighbourhood Health fits into Cheshire, Merseyside and the national context. And then we will focus on Sefton, the two Cheshire and Merseyside pioneer areas of Sefton and St Helens. So we've got colleagues Angela White from Sefton CVS, Rachel Jones, Sefton CVS, and Tracy Jeffs, who's the interim place director at Sefton, who'll be outlining their model and what they do and how the VCFSE sector is a core part of their delivery. And then we'll be going to St Helens to hear from Sally Yeoman, from Rachel Frankland, and to get a sense of how the sector in St Helens is a key part of the neighbourhood health model. Then it's the Q&A, summary and final thoughts, and then close at 11:30. These are my slides just to give a bit of context. So nationally, the NHS 10-year plan has now been published, and the government have outlined their ambition for improving neighbourhood health. So it's a big part of the 10-year plan. We go to the next slide, Joby. At the start of the year, I think it was the 30th of January, the NHS published neighbourhood health guidelines, and within this they outlined 6 core components. So these are the 6: population health management, more about the data, GP and modern GP practice, standardising community health services, so that's where larger providers like mental health and other community trusts connect into neighbourhood health delivery, multidisciplinary teams at neighbourhood level, integrated intermediate care with a home first approach, so that's the hospital discharge patient pathway management that links into the urgent neighbourhood services. So that these are the 6 core components that people are looking at as part of how a neighbourhood health model should develop. This is the current definition of Cheshire Merseyside by what is meant by neighbourhood working. So you can see the key role of neighbourhoods, and then for the NHS, the importance of integrated neighbourhood teams and multidisciplinary working about where things connect together. And all health systems across the country have been working on developing what their neighbourhood health models are and how they should support it, but there will be extreme local variation, as we've seen across Cheshire and Merseyside. To support all of this, I've just put here the slide from King's Fund around their future ambitions for what neighbourhood health working should look like. But there is a national programme that's been set up by the Department of Health and Social Care called the National Neighbourhood Health Implementation Programme. It's a bit of a mouthful, isn't it? But it's NNHIP, National Neighbourhood Health Implementation Programme. So there was an application process earlier this year, which was extremely well applied for. 8 of our 9 places in Cheshire and Merseyside applied, and there was a strong competition from across England. 43 pioneer areas were selected, and the aim of the programme is to support those places that are doing best. So these were the best areas in terms of their neighbourhood health model. But the plan is that the learning from those areas is supported in order to speed up how good practice is put in place across every neighbourhood in England. When we recently got the chance to talk to the senior responsible officer of the National Neighbourhood Health Implementation Programme, and key for her was the importance of place, so that's the local authority for us in Cheshire and Merseyside, and the relationship to each of the neighbourhoods, and in particular the role of the voluntary community faith and social enterprise sector she saw as being primary in how this model should develop in a really way. So today, that's what we're going to look at as part of the 2 pioneers in Cheshire and Merseyside, and find out what they're doing in order to champion, support and build their neighbourhood health model and the role that the voluntary community sector plays in it. So I'll stop introducing, I've run over, but I think we started a little late, and I'll hand over to Tracy Jeffs, Interim Place Director at Rachel, and colleagues Rachel and Angela, to talk about the pioneering work of Sefton and the role of the sector in that.
Thanks very much, Warren, and thank you very much for inviting me here today to tell you a little bit about the work that's going on in Sefton, along with Angela and Rachel. So if you move to the next slide, as a pioneer site for the national programme, we are delighted to be able to share the kind of priorities that were highlighted in that application and some of the local work that we're doing, which we think contributed to us being selected as a pioneer site. There were 3 priorities within our proposal. And you will see through the presentation that the voluntary sector runs through each of these areas of work as we go through. So one of our areas was working around primary care at scale. So that's around our primary care networks, our GP federations, all working together with other partners across the system. So that will include the voluntary sector, Sefton Council and other partners, to look at what that multi-neighbourhood provider model will look like in the future. And we're fortunate in Sefton in that we have a long-standing geographical footprint which aligns our primary care colleagues and other partners in the system, and voluntary sector colleagues are embedded in those teams working across those 8 neighbourhoods in the borough of Sefton. So we're in a good place to build on that, working at primary care at scale and working with other colleagues and partners in those 8 neighbourhoods. So the second area was building on those stronger partnerships. We have a long-standing tradition of very collaborative working in Sefton across all partners, and our voluntary sector partner is at the core of that and are a key part of the system in terms of that community-led approach that Warren has mentioned previously, along with other partners. And some examples of work where we're trying to progress that is around some of our estates work. We've got 2 key estate developments that we're hoping will become part of the neighbourhood hub approach, but we've also got a number of areas where we're co-delivering services from different partners already across the borough. And then the third area was really trying to use the neighbourhood pioneer approach around meeting the diverse needs of the borough. So those of you that maybe aren't familiar with Sefton, the borough stretches from north of Liverpool all the way up the coast to Southport, and quite diverse in terms of the different types of communities, geographies, landscape in the borough. And we have a very elderly population in the Southport and Formby patch, and we have a more sort of inner city socioeconomic deprived population in the south, but pockets of that across the borough. So one of the things we were able to focus on in our application was what can we do around looking at that population data, how can we be proactive and work as a system around key cohorts to improve population health. And the 3 areas that we identified were around long-term conditions, frail population and young people, particularly with a focus around mental health. So they were the key threads in our successful application. And I think the reason we were successful was it was very much evident from the application. It was built on very strong relationships and embedded working for many years has gone on across different parts of the system, and I think that was reflected in the application that went in. So the next slide just shows you some of the partners who are working in the Sefton Neighbourhood Health Partnership. We have a range of NHS providers. So we have 2 acute providers at Mersey and West Lancs and the Liverpool Hospitals Group. We have a community and mental health provider in Merseyside. We have Alderhay providing services as well. Sefton Council is our local council, as you would imagine. Good connection with community pharmacy, and of course our primary care network, Sefton CVS, who are on the call today, and Sefton Health Watch, some of whom are our key partners in our neighbourhood approach and on the board. And the next slide, I think, talks a little bit about the governance that we have. So reporting to that neighbourhood board is a neighbourhood model operational group, and within that there are a number of work streams which have been evolving over recent months, building on what we've been doing before. But the opportunity of the neighbourhood programme is that we've refreshed this and are working together with colleagues to make sure that we're as organised as possible and responding as quickly as required. So some of those groups reflect the 6 key areas that Warren mentioned around the national guidance. Got leads from across the system leading on each of those 6 boxes there, which mirror those 6 areas. But I suppose for this audience, it's probably really helpful to pick out the box in the yellow there, the people and communities group. And we're very fortunate in Sefton as we've had this group in place for some time. All members from the Sefton Partnership on the previous slide are represented on the People and Communities group. And we use this as a way of trying to ensure we coordinate ourselves as a system to be as community-led as possible. And we listen to the views coming from each of our colleagues from local communities and patient experience, and try and work as a system to co-design solutions and respond to the themes that are emerging from different communities across the borough. And one of the key pieces of work that that group has developed, and it's been led by Rachel and Angela in Sefton CVS, is a community insight tool which we've been piloting, and we're hoping as part of the neighbourhood model approach to really share that more widely across the system, so we can continually collate themes that are coming up from all our communities in a systematic way and feeding that into the partnership. And that group reports regularly into the partnership board around the key issues and key challenges and responses that we've coordinated as a system. So the next slide just gives you some examples of some of the key pieces of work that we highlighted in our Pioneer bid. These are some of the more clinical, I suppose, areas that we highlighted. Our work across the system around supported discharge and admission avoidance. The work around our integrated care teams. We've had in some of our areas, we've had integrated care teams for more than 10 years. And that has included in 4 of our neighbourhoods a health and wellbeing trainer post coordinated by Sefton CVS. So we have always had voluntary sector at the heart of our integrated care teams, and more recently connectivity with the social prescriber link worker service, which is a common service delivered across all of our 8 neighbourhoods in conjunction with our primary care networks and Sefton CVS. And then the Home First programme, which is trying to ensure that people come out of hospital direct to home as much as possible, and part of that is also a voluntary sector offer. The next slide talks about 3 other examples, which again show the integrated working in Sefton. One example is a primary care network, our South Sefton PCN have run in conjunction with partners a very successful adverse childhood experiences programme, where participants undertake a 10-week trauma-informed approach. And this has really evaluated extremely well. It's been evaluated independently, and some of the impact of that programme is people have gone on to access a greater range of health opportunities and really improve their self-esteem and coping strategies. So it's a really key programme with the voluntary sector, with our PCNs, and some of those participants have gone on to actually volunteer on the programme in future. So a real example of health in its broadest sense, clinical, but also that wider wrapping around the needs of the individual using that community engagement approach. Children and young people, primary care, mental health pathway. We've been piloting a programme in conjunction with Venus, which is one of our mental health voluntary sector providers, with Alder Hay, really trying to get upstream around some key groups of children that require some support. And then in Southport and Formby, our PCN has coordinated a complex lives programme, particularly around a challenge cohort of patients, of residents, homelessness being one of the key features, working again in a multi-agency way. So just some examples, I think, of the breadth of work. It's not the only work that's going on, but some of the examples, I think, which highlighted the strategic and partnership approach in Sefton. So the next slide just highlights some of the key themes of our approach: prevention and early intervention, collaboration and integration. Using our data and insight, we now have information packs across each of our 8 neighbourhoods to help teams coalesce and consider what is required alongside that community insight and professional view. Our neighbourhood and locality focus, we might need to do something different in each of those neighbourhoods depending on our different population, and trying to be simplify things as much as possible, trying to clarify pathways and make sure we have that real team approach in each of those areas, building on integrated care teams, but really getting to the next level for that wider ambition that Warren talked about earlier on in the earlier presentation. So the next slide is just something we've actually pinched from one of our regional events. We went to the first national implementation programme event in Manchester a few weeks ago. And this slide was developed by North East Lincolnshire, one of the other pioneer sites, and we really liked it actually, and we thought we would steal it for a start and then maybe develop it later on. And this is a way, how do we make neighbourhood health, how do we describe that in a way that it makes difference to our local people and communities? And there's a few examples there about making it easier to see your GP, providing more care in the community, focusing on those who need extra help through those more proactive care approaches, acting early, helping people manage their own health, and working as a team around you. So really nice, simple messages. So thanks to North East Lincolnshire for that. And I think that sort of wraps up my part of the presentation. I'll hand over to Angela and then Rachel, because they can describe a little bit more about the partnership work, which is at the heart of our work in Sefton. So thanks very much.
Okay, thank you, Tracy. And thank you for the opportunity to speak about the Sefton experience. Could we just move on the slide, please? I thought I would just give you the voluntary sector context locally. Basically, we have around nearly 3,000 voluntary sector services being delivered in the area, covering the whole borough, where you can see on the right is the geography, Southport up at the top and Bootle at the bottom in blue. It covers 3 locality areas and 8 health areas. And of course, the important context is what is considered to be the locality to our residents, which is really a key message that we're putting into the discussions with our partners. Coming back to the groups, there are around 2,000 organisations and services delivered locally and physically located in Sefton. And just some figures from the Cheshire and Merseyside State of the Sector report, which was commissioned through Voluntary Sector Northwest recently. We estimate the voluntary sector workforce to be just under 4,000 employees, nearly 40,000 volunteers in the system, and the contribution of the voluntary sector to the GVA is approximately 70.8 million into the Sefton economy each year. So that just gives you a feel for the voluntary sector. And the important thing about Sefton's voluntary sector, it very much reflects the geographies. You see the geography there, but it's all small townships. When it was actually pre-1974, it was all townships such as Maghull, Bootle, Crosby, all areas that have got very strong community identities and lend themselves very much to that micro hyper local working. And most of our groups are micro groups or very much embedded in neighbourhoods. Could we just go to the next slide? So we've just got a slide from NHS England about the use of community health assets, and all of that will be very familiar to the people on the call today about how vital community assets are to the delivery of health and community outcomes. And part of the role of the voluntary sector in neighbourhood health is around engaging in community-based services. And already there's that aspect of happening in Sefton, and as Tracy alluded earlier to, reducing hospital admissions, ensuring care closer to home, home first, are all of the initiatives already voluntary organisations have a footprint in, but also can step up as part of the ongoing neighbourhood planning. And I think addressing health inequalities and preventative work are very much linked in terms of voluntary organisations in Sefton contributing, as they do in the Northwest, around tackling those long-term health inequalities, addressing issues around childhood poverty, poverty in communities, disadvantage, people being furthest away from health services. And we have examples of the sector locally delivering in collaboratives through warm spaces, very small organisations engaged there at locality level, and to bigger collaborations with public health around living well, and looking at interventions to reduce health inequalities. And again, I think the sector has said in the planning groups prior to locally how important their role is in preventative and early intervention. And I think that message is being clearly understood in the system and from some of the priorities that have already been identified in the neighbourhood system. Tracy's alluded to integrated neighbourhood teams. That is happening, and I think there's more opportunity for that to happen as we develop those neighbourhood teams in the 8 localities, certainly through connections to community hubs. Certainly we've been talking about that, and their potential to do even more around connections around wraparound support, also make every contact count. All of those are vital and parts of what a community hub and community organisations offer. And of course, diversifying and ensuring community voice and seldom heard groups are specifically held into the system at the highest level in terms of local delivery, co-development and co-design of services. So just move on. Opportunities already that is happening, and I'm sure is happening in other areas, ensuring that strategic representation of the voluntary sector is undertaken in all of the key strategic groups, and that is right across the system. So the CVS certainly has seats on the Children and Young People's Partnership, on the Integrated Care Partnership, Neighbourhood Health and Wellbeing Boards and so forth, but also our Health Watch colleagues are key participants, and voluntary sector organisations through our forums are connected into the system at the highest level. But we will also see more opportunities as the neighbourhood teams develop, and whether that's thematic or specific interest to locality and neighbourhood, that's being developed just now. Rachel's just going to comment on community insights and what we're attempting to do with that. But already we've actually undertaken with the wider voluntary sector social action research and community voice with our voluntary sector partners in things such as the Community Drugs Partnership, and hearing the experiences around drug and alcohol misuse from participants who are engaging directly with our voluntary sector providers. So more opportunities to do that from the range of expertise within the sector. And again, I think new developments in new models of care, that's being developed through Home First. We've also got opportunities around waiting well, those people engaging in adult social care system. So enabling your system locally to ensure that voluntary sector organisations can come forward with solutions that are designed in connection with their users and residents. And again, we've talked about ensuring the locality neighbourhood working opportunities. Just moving on. I just thought I'd show you the social architecture of Sefton. It looks very busy, but it is very connected. The yellow elements are our key forums. So you'll see we focus in the main elements there of Every Child Matters, which is children, young people and families. And in the centre there, Health and Social Care Forum, which covers around the adult issues and mental well-being. So you can then see in the grey, that's the voluntary, the social architecture and policy architecture of the current system in Sefton, and we ensure that's interconnected going up and across to ensure voluntary sector voice is at the heart. We've also got some emerging themes. We've got, believe it or not, we've developed an arts and culture programme and a Sefton Performers Network. I'm not quite sure how that developed, but it came through really local organisations wanting to engage in the cultural strategy and development of Sefton. We've also had specific groups in response to the tragedy in Southport, which is continuing in terms of a voluntary sector programme. So you can see with equalities, there's user voices, and then we've got some cross-cutting consortia and collaborations around digital inclusion, health inequalities and emotional achievement service in collection connection to children, young people and well-being, which again is involving a range of voluntary organisations. And then you can see the connection up to the region at VS6, Voluntary Sector North West, and up to NAVCA, our national organisation. So it just gives you an indication of what the system and the social architecture's like. And I'm really grateful for the support that we have from the NHS locally and the Sefton Council, who acknowledge how important that is to the social fabric of Sefton. And then moving on, I'll pass over to Rachel. Thank you.
Yeah, thanks, Angela. So just leading on from Angela's articulation of that wider network and reach into the sector, I'm just going to share some practical examples of ways the sector have been involved in neighbourhood health in Sefton. So I know we've mentioned that community insight and voice and how important that is. And what we've built on in Sefton is an insight and intelligence tool. So this is anything that it's a tool that any local organisations can use. It's aimed at frontline workers, volunteers, staff, and they just click on, there's a QR code, you're welcome to have a look at this. There's a briefing and a demo video, and what it invites people to do is just submit what they're seeing on the ground in their communities. It's not about patient experience or individual issues, it's about big issues affecting local communities. So the types of themes we've had through are like transport can be barriers to access services. There might be gaps for particular groups. A key theme that comes through is loneliness and isolation for older people in the borough. And I think a good example of how this tool's been used was when we started it initially. We got insights that there was issues affecting community in Bootle, which is the south of our borough, high levels of deprivation. Around harmful gambling, and the sector was saying there isn't much support for people affected by this issue. And our public health colleagues then commissioned harmful gambling training to skill up the local sector in that area. And there's other examples again where we're sharing those insights to respond to community need. And the people and communities group that Tracy referenced really value those insights, because we do know there's such differences in our local neighbourhoods, aren't they, that we drill down so they can be quite distinct issues. And what's been a real positive for Sefton, I think, in the neighbourhood work is I think Tracy mentioned there's neighbourhood profiles for each area, and this our insights, the qualitative data, are overlaying the health stats and the demographic data as well. So it's providing quite a rich picture of those individual neighbourhoods. So again, have a look at that after the call. The website's always up there with that tool on. If we move on to the next slide. We used our annual conference this year to theme it around neighbourhood health and provide an opportunity again to engage the sector in this space. So we pinched the idea from a hackathon that myself and Tracy and other colleagues in the system attended early in the year at John Moores University. And it's sort of bringing people together to say, what are the challenges, what are the problems, and how could we fix them and innovate? So we had a really well attended session. Participants were enabled to come up with define their own problem or challenge as they saw it and come up with some solutions. So we've had some really good feedback, some really good ideas, which I think we're going to work up. We would have worked up regardless of the neighbourhood health and the pioneer status, but it really helps to leverage it and get that buy-in a bit wider and a bit stronger. So again, we'll be sharing the outcome of that into our people and communities group and the governance structure around neighbourhood health. And then a final example was about children and respiratory health. If we just move on to the next slide, please. So one of the task groups, the children and young people's task group, because we had the pioneer status, we were able to apply for some additional funds to support a pilot work. So it was a modest amount, but significant. It was 35k. Which we were successful in getting. And what that's done is built on an already existing pilot around children's respiratory health. And I think that's something we've reflected on from the outset of this journey, is there's loads of good work going on already in this space. And I'm sure that's the same for everyone in the call. And we don't want to just ignore that and forget about that. We want to build on and enhance it. So what this does now is build that pilot up more so that there'll be an integrated team around children's respiratory health that brings in those clinical inputs with non-clinical. So for this model, we've got parent champions who are based in voluntary sector organisations. So when families have had clinical interventions, they'll go out into maybe do home visits, and what the workers will do is see, you know, is the mould on the houses, is the window broken? And they'll do that work with landlords and supporting the family to address those issues. It could be that parents are smoking, there's family stress, maybe not well educated about how to support the children's respiratory health and promote that. So they'll do those non-clinical interventions with families, and the pilots initially saw really, really good outcomes. So we're really excited to build on that. And the new Neighbourhood group around that brings in wider representation and education. Education colleagues, sorry, not education to people, but schools as well will be involved in that. So it's just expanding its reach. And I just put a note on about investment to enhance the sector's capacity, because we're mindful that, you know, new opportunities to work with the sector are very, very welcome. But also this part of that funding was given to a local voluntary sector organisation to enhance that capacity around the parent champion post, specifically to work with families referred to this new integrated team, which is really important, is that we're mindful that we all need resources, but we think that's a really good example of how you can bring clinical, non-clinical, voluntary sector all together around a family, around a condition that will yield positive benefits. So I think that's the end of our slides. I think by some miracle, oh no, sorry, one last one, sorry. I thought I'd finished on time, so I'm going to go over slightly. But we thought it'd be good to just reflect on some top tips for influencing neighbourhood health from our learning. So as I said, build on what's already working. If you've got those partnerships, strong partnerships, examples of good integrated teams, build on that and learn from that. Consolidate the voice of the sector via collective forums and alliances. I think being able for health and wider system colleagues, having those forums and networks where we can bring the sector together makes it easier to have that ongoing dialogue. We put co-design and co-produce services from the start, and have capitalised start, because I think sometimes there can be a pressure to deliver nationally, can't there, as well, but we mustn't forget how important it is to involve local communities and the voluntary sector in plans and shaping that. Share local intelligence and data. So anything you can do where we can share those insights and what the sector's seeing, I think is really welcome from colleagues. And then the final two are about championing that health equity and, you know, really advocating for people and communities who do experience those wide gaps in life expectancies, and alongside that, really championing, you know, the assets of the voluntary sector, whether, you know, that being physical and non-physical, that what they offer is very unique, very distinct at that local, hyper-local and neighbourhood level, and should be used where possible in the system. So I think that is my last slide now. It's just a thank you slide next, and I don't think we've ran over too much, so I'll just stop there and hand over seamlessly to Rachel and Sally from Halton and St Helens VCA for the next part of the session. Thank you.
Thank you for that. Brilliant. So thanks everyone. Thanks for inviting us. Again, we're really pleased to be here and share what we've been doing in St Helens. So I guess, as you can see from that slide there, again, that kind of demonstrates some of the partnerships and partnership working that we have in St Helens as we kind of start to embed our neighbourhood health approach. Similar to Sefton, we kind of have, oh sorry, if you could just go back to that next slide, the last slide please. Yeah, similar to Sefton, we have kind of a range of kind of primary care networks. We actually are served through our health, acute and community sector through one provider, which is Mersey and West Lancs, and then equally Merseycare provide our mental health and some of our community therapies, and then we have our 0 to 19 service provided by Wirral Community Health Trust. And as you can see, kind of, and Sally will talk a little bit about our voluntary sector involvement as we move through. So if you can move on to the next slide, please. So yeah, I'll not spend too long on this, and I think the next slide is even has already been covered, but yeah, I guess, you know, our neighbourhood health approach is kind of based on 3 top priorities that have come out of the 10-year plan, and they are with a real focus on moving from hospital to community, from analogue to digital, and from sickness to prevention. So if you can move on to the next slide, please. Thank you. I think this one's already been covered, but I guess, yeah, so as part of that kind of 10-year plan, we are working towards some more very specific guidance, which came out in February of this year. And this really is around trying to just join up our working. You know, as Sefton have already kind of alluded to in St Helens, we do already do quite a lot of that kind of integrated, joined up working. But it's about how we can develop that even further, strengthening that kind of primary and community-based support for people to be able to access the support that they need closer to their home, and then connecting people to the services that are actually being delivered within their local community, as opposed to asking people potentially to travel to other parts of the borough to access that support. Next slide, please. So this is just a bit of bragging rights, really. So I guess like Sefton, we were really, really pleased and ecstatic to be kind of awarded that pioneer status. As it's already been kind of alluded to, we, you know, we were kind of competing against, I think there were about 140 applications across the country for 43 places to become one of this Wave 1 pioneer sites. And like Sefton, in August of this year, we kind of got together as a partnership to document as part of our application all of the integrated work that's already kind of happening in St Helens, which I think, like Sefton, kind of helped us to secure that kind of bid to become one of the initial Wave 1 priority sites. Next slide, please. So really, it's, you know, we talk about kind of the government policy, we talk about, you know, procedures of what we're being asked to do, but actually, what does that mean? What is it that this programme means for us? What are we specifically being asked to look at and focus on as we develop our neighbourhood health approach? So as you can see in the middle there, this is kind of the specific ask from the national team in terms of, as part of this kind of pilot and pioneering prototyping, what group of people do they specifically want us to kind of focus on? So we are being asked to focus specifically on people with multiple long-term health conditions who are at risk of hospital admission. So over there on the left, this is what we are planning to do in St Helens to address that. So we want to be able to find those people with long-term health conditions and make sure that we're targeting this to those people that need the most support. How are we doing that? Well, we've got a population health tool in St Helens called Cypher, which combines kind of primary care data, acute trust data, and local authority data. And what that allows us to do is kind of run searches for those people to be able to identify, as it says there, those people who might have multiple long-term health conditions. We can filter that by age. We can filter that by the number of times people have attended A&E or the number of hospital admissions that they've had. So that allows us to kind of narrow that down to a really specific list of people who meet that criteria. So that's it. So we're getting there where we've kind of managed to get our list of those people who need that support. Then we're going to bring all the right people around the table to be able to talk about what those persons' needs are and agree on a plan to be able to help them. After that, we're going to look at developing our integrated neighbourhood teams that are based in those neighbourhoods to help people, you know, and kind of receive that support and care in those neighbourhoods, making sure people get the care they need as close to home as possible. So through doing all of that on the left, this is what we expect to see on the right. So we would expect through that we would see fewer people needing to go to hospital for appointments, fewer people needing to go to A&E or being admitted to hospital without planning, making it easier for people to see someone at their GP practice when they need to. And I think when we kind of talk about increasing that access, that really is about people seeing the relevant person that they need to see at their GP practice, and that might not always be a GP. And then the last two are around kind of how it feels personally for people who are part of this. So we want to support people who've got multiple long-term health conditions to feel more confident in managing those conditions and knowing what to do to look after their long-term health problems. And then equally, we want staff involved in this programme to feel happier and more supported at work. Next slide, please. So this, I guess, just summarises some of what we've been doing. So from September, I think Sefton might agree with this, from September to now, it's been a bit of a kind of hit the ground running. You know, it's been moving at pace. We've been asked to submit quite a lot of information to the national team. We've been asked to kind of, you know, report on outcomes already. So this is kind of what we've been doing in St Helens. So a bit like kind of Tracy alluded to in terms of the governance. So we kind of have aligned our governance now, and kind of within that governance, we've formed what we're calling our Neighbourhood Health Task Force group. And that group meets monthly, and that's where we start to kind of think about some of the strategy and planning of how partners can work together to develop this approach. So we've had 2 meetings so far. They've been really well attended, between kind of 30 and 35 different partners from across organisations, including the voluntary sector, attending that group. And that's kind of where the decisions are being made about, okay, how are we going to progress this? How, you know, what can we all bring to the table to progress this? We've also completed a number of assessments for the national team. So I think in October we had to do a maturity assessment. Then last month they wanted a baseline assessment. So we are being quite tightly kind of monitored on this in terms of, you know, what we're doing, when we're planning to deliver it by, etc. Which I think is, you know, it's good in one way, because we are being kind of, you know, we're being expected to report. And I think, like Tracy said, you know, and the guys from Sefton, you know, we are already doing quite a lot of this work. So a lot of it isn't kind of new stuff. We're just reporting on what we're already doing, which I think is quite nice. As I've already alluded to, we're using our population health tool to get that list of people who need that support. And we are now in a position where we have agreed our prototyping cohort, so the groups of people we're going to support in which neighbourhoods. And that, I think that's on a later slide. Also within the, sorry, can you just go back? So yeah, so also in this, we have actually, so there is no funding to develop this approach kind of across the programme, but in our programme, we've managed to secure a small pot of seed funding to develop a children and young people's cohort or group within this approach. And how that came about was a bit like Sefton, you know, we were kind of looking at the work that's already going on outside of this before we even kind of knew we were going to be doing this. And in St Helens, we have the Families First programme that's happening in St Helens, and that's again a national local authority programme about the reform of children's social care services and early help support. So we've kind of liaised with our colleagues in local authority and thought, oh, okay, well, if that's already going on, they've got this dedicated team in an area of St Helens where the need is greatest. And we kind of have been to them and said, right, okay, how can we link this to that? How can we support the work that you're doing for the social care of these families? How can we provide that kind of health and wraparound support, voluntary sector and community support? So that's what we're doing there. As Tracy said, we also attended the regional workshop in Manchester in October, and we were fortunate enough to have 16 of our partners from across the sectors, across the services, who attended that with us. To be able to kind of hear about what work has been going on across the country. So we were hearing about models that are already really well established in terms of, you know, York, Cornwall, London, and think about, okay, so how can we kind of learn from some of that information? So in St Helens, then we had kind of a debrief meeting. So 8 of us kind of came together in November and talked about how we might be able to share some of that learning. Some of it probably we wouldn't be able to learn because these people might have been doing this for several years with a lot of extra money. But it's about, okay, how can we utilise what we've got, our current assets, our current funding streams, to be able to develop this approach in St Helens. And then that bottom one there, we've already kind of started to do some of our engagement workshops around this particular approach and how we might develop that. So we have hosted 2 workshops with our voluntary sector partners. We had one on the 17th of November and a second one on the 27th of November. And the focus of that is really to provide as many people in St Helens with the context of what we're doing, the context of the ask, to think about what we're already doing that might just need shifting across, and then what we might need to start as a part of this programme. So we've done two workshops with voluntary sector partners. We also did a workshop with all of our primary care colleagues in November. So we had over 100 people attend that event. And again, that was getting to for primary care, for our primary care networks, to think about what they might need to do differently to support this approach. And then we had our first kind of meeting with leads within our acute and community trusts at the beginning of this month, again, where we were kind of asking that same question. Move on to the next slide, please. Okay, so I alluded in previous slides about we've run our population health tool. We've been able to look and pull out those people who we think meet the criteria to kind of receive this help in our initial prototyping cohorts. And as you can see there, so in St Helens, we're actually going to be working across 4 neighbourhoods. So that's been quite a challenge in itself, because our local authority have 7 localities, our primary care networks have 4, and it's how we kind of map that. So we have done some mapping across that, and we are going to be developing our neighbourhood approach across 4 neighbourhoods. And we now, as you can see on the left, have kind of agreed and decided specifically what groups of people we're going to be supporting as we prototype this initially. So the north are going to look at helping older people aged 65 and over who have multiple health problems and who may be frail. Then Newton and Haydock and South are both going to be looking at the same group. So they're going to be looking at adults aged 18 to 40 who have more than one lasting health problem, including a respiratory focus. So that's those people will have either COPD and or asthma. And then finally, we have our central team who are going to be supporting that Families First programme in PAR, which I talked about, supporting children and young people who have more than one lasting health problem. Next slide, please. So what do we mean, I guess, by building our integrated teams? So I think, as Sefton has alluded to, again, in St Helens, we are already doing some of this work. So throughout 2023 and 2024, we've been running a programme in St Helens called Care Communities. And that is where we have been kind of doing this. So we've been kind of working in 4 areas where we have kind of collectively developed a list of people who need additional support. So, for example, our last cohort of people that we discussed in those kind of collective meetings were children with poor school attendance. So that would be children and young people, complex families identified by local schools as having poor school attendance. And we would kind of host multi-agency meetings in those 4 areas to kind of discuss and plan that care. The bit that was missing from that piece of work, and the bit that we're going to develop in our neighbourhood approach, is the delivery of that care and support. Because although through Care Communities we were able to get people together to talk about these complex families and children and agree a plan, what we then found is people then do go off and do their plan, deliver that care kind of separately. And what we're now looking at is, well, how do we deliver that care as one team? So in St Helens, we are looking at developing 4 integrated neighbourhood teams. And the idea is that that team will have collective responsibility for improving the health and wellbeing of people in that community, with an integrated leadership for each of those IMTs. The focus is delivering holistic care, flexible, joined up, and hopefully preventative. So by shifting from that risk-averse approach, the idea is the team collectively holds that responsibility for the people that they are supporting. So in order to do that, we're going to be looking at building kind of trust and working relationships, trying to remove those referrals and current barriers between organisations. And how that might look is around kind of redesigning working days, co-locating teams, having daily huddles, and things are already kind of starting to move in that direction. Next slide, please. So I'll now hand over to Sally, who will talk a little bit more about the sector's input into this.
Thanks, Rachel, and colleagues from Sefton. So I was just going to, I think we've talked quite a lot about neighbourhood health. So one of the things that I wanted to talk about was the context and circumstances that already existed in St Helens that I think mean something different and make the difference in terms of St Helens, and I think Sefton. So really why it's pleasing to see that our two places were invited onto that Pathfinder, because I think the way that partners work with the voluntary and community sector in those two places sort of set the scene for how we might embed the sector into neighbourhood working. So I think Rachel's helpfully included in the slides some of what voluntary and community groups have talked about on this one and the next one. We won't move on yet. But I think that gives a bit of a flavour of what organisations see themselves doing. But I think I wanted to highlight some of the things that I think are already going on in St Helens that have really and will make a difference in terms of the voluntary and community sector being able to participate fully in neighbourhood health. So Rachel's covered off what we've been doing over the last couple of years, but I think there is a post-COVID world in St Helens, and I'm sure for everybody else. But and that's meant some really dreadful things, hasn't it, for lots of people and for lots of us. But actually, I think it changed the relationship and moved us on a step or two. I think partners in St Helens fully understood, if they hadn't already, the impact that the voluntary and community sector can have in all sorts of different ways. And I think that was a benefit to the sector. So particularly in terms of health and social care, it was easy to identify how important voluntary, community, faith and social enterprise groups and organisations were, and the role that volunteers can play in helping to improve health. And I think that set the scene for the last 5 or 6 years of working together in St Helens. I think one of the things that's really important is that we have a strategy and approach called St Helens Together, which sets out the context and circumstances for working with the voluntary and community sector, not unlike Sefton with your strategy and approach that you've had for a long time. But I think that really helps to set the scene. And so when we embark on programmes of work or when we redesign the way we might deliver things, there's an obvious way of engaging with the voluntary and community sector. And I think that's really, really important. We've had already played a role in terms of care communities and in the work that the council was developing around localities. And I think that's helped to set the scene to help partners understand what might be possible and the sector to think through how it should mobilise and arrange its services. And in terms of the slide Angela presented, we've got some information and data about how groups operate and where they operate and what the sector looks like in those areas. And I think that really helps in terms of planning. We've got real integration in St Helens in terms of the way that money's spent with the sector. So the council and health partners do that jointly and collaboratively. And so often that can, we get the sort of best option in that. So the council takes a lead role in terms of funding and resourcing the sector, and health money flows into the council to do that jointly. And I think what we felt from a sector point of view is that we've seen a bit of a modernising of that approach over the last few years. So it's always, isn't it, the really kind of key issue for groups is the resource to do what we need to do. But we've had a bit of a can-do approach developing. So some direct awards for organisations that have been the provider of something. So although sometimes people think that that's not competitive and that other groups might not get a chance to do that, I think when you've got an outstanding organisation set up to deliver something, actually it's right that public sector partners do make direct awards and work with that organisation collaboratively to address any of those issues. Longer contracts, so really using procurement to help make that happen, and an approach to adding in uplifts to working collaboratively with us on the impacts of national insurance. So I think what I'm trying to say is all of that kind of setting the scene to help the proper embedding of the sector. I think Jane's asked a question in the chat if colleagues are following that, but I think, you know, we're about to embark on a period of uncertainty, I think, in terms of funding for groups. And I think it's really important that we've got the context set so that there's a real live look at what's happening for groups and how do they properly participate in neighbourhood working and this particular programme in St Helens. And then we've got a number of initiatives and projects that I think really connect nicely into this, and some key organisations. So to Dave's point earlier, I think both of us presenting from a CVS point of view have some governance arrangements in place about how the sector comes together and can help shape the work that we're doing. And we've got some frontline providers connected into that. So where that's, you know, when we talked about Rachel's slides in terms of the specifics of what will happen in St Helens, those organisations that link into that, I think, connected into that work. And we've got a workshop tomorrow in St Helens where groups and organisations will be participating in helping to shape lots of that. And then just the other thing I wanted to touch on was how important some of the work that's gone on around health equity and our Inequalities Commission is, in terms of understanding that we live and work in a place where people are often less well served. And I think really ambitious for the way we're working to make a difference in terms of people's health outcomes. So I think our Inequalities Commission's done a really great job of highlighting if you do something differently. So we've done something differently on loneliness and isolation, and on stigma in particular, that we can start to change the dial on some of these issues. And lots of that's about the way we work collaboratively together. So we've had a 3-year lottery funded health equity project, which has really been about a focus on the voluntary and community sector, and communities are central to the way we all manage our own health going forward, accepting that lots of people don't have the agency and aren't working from the same platform, but that, you know, our sector's got a really key role to play in being the kind of bridge towards some of that. And I think we've got really solid foundations in St Helens, a really strong track record, and I think some of those things have really helped us in terms of enabling the sector to play a really key part. So I think that's probably it from me.
Thanks, Sally. So yeah, just our next steps. We have got, like I say, so we've got a number of meetings and workshops planned over the next kind of few weeks and months. Our task force group continues to meet monthly. We as part of our care community programme, we did have an oversight group, and that now is just going to shift slightly to become our integrated neighbourhood team steering group. So we're due to meet for the first time on the 17th of this month. Our task force group meets again in January. We're going to try to continue the engagement with our residents in St Helens. So I'm going to a number of GP patient participation groups. We've got some local authority and voluntary sector groups through our workshops, where kind of this information is going to be kind of shared and then get that feedback gathered. And then what we are planning in January and February is to host some specific neighbourhood workshops to get those services and groups and communities together in North, in Central, in South, to discuss specifically, you know, the cohort that we're going to be looking at and how we're going to kind of move this forward as we move into 2026. And I think that's it from us. Yes. Thank you.
Thank you very much, Rachel, Angela, Tracy, and Sally. I really appreciate that. Not only for what you've done today in terms of sharing the learning, but in terms of driving the conversations and making this happen to such a point that you're recognised as pioneers. Shall we unshare the slides? Shall we just, and we'll come back to that last one at the end. We'll move to the Q&A. There's been a few questions in the chat, and I know there's been some responses in the chat. but does anybody want to come in and ask a question at this point? If you want to put your hand up and then say who you are and then ask your question, that would be really good. There was a few unanswered. There were some big questions in there in the chat. If no one wants to speak up, I'll try and draw out some of the questions we saw. I think it was a big question. We've got a hand up, Dave.
Yeah, thanks, Ron. Yeah, it all sounds extremely exciting, and sadly, I've been around long enough to remember the old community health services many years ago. But certainly, yes, and thanks very much for that, Angela. But there certainly is a lot of opportunities, I think, now going forward for the sector, which we're ready, willing, and waiting. I think we're all sort of anticipating what is going to be happening. Just Warren, the whole issue with the ICBs at the moment, and sort of all the cutbacks that they're actually making, at the moment it just feels extremely stagnant, and we seem to get lots of good conversations like we're having today, but then you've got this shadow over the other side that we're really worried about. How's that going to affect, or what's your experience? I mean, come on, you've been around long enough as well. What's your thoughts about how that's going to affect what we're doing? Is it going to enhance what we're doing, give us more opportunities, or is it a threat?
It's certainly a threat. It is a big concern in the background. We've got a new chair and a new chief exec at NHS Cheshire and Merseyside now. They're making very positive noises around the future of collaborative working, partnership working with the VCFSE sector, and people like Rachel Franklin and Tracy Jeffs are key partners in making sure that the conversations at system level translate into a reality of partnership, not just that kind of high level rhetoric. The money is a massive concern. It's the priority. It's the biggest problem that Cheshire Merseyside currently faces, and I think we're probably at the bottom of the list of the 42 systems in terms of where we're at in terms of that conversation. That does prompt conversations that the new chair, Sir David Henshaw, wants to have. How do we turn this? One, how do we get better financial grip across relationships and partnerships with NHS partners? But then two, how do we get to a point where we can't just carry on doing things as we are? How do we create a new way of investing in some answers that turn around that financial challenge and the challenge that communities and people face in terms of the outcomes? It's always going to be a fine balance, but we've got to start getting into how we scale up the role of the VCFSE sector at Neighbourhood in particular and place. Otherwise, we're just going to be going round and round in circles as we have done for the last 15, 20, 25 years in terms of conversations around NHS delivery models. It won't be easy to shift to that new model, but it's got to be built into the next conversations around the next 5 to 10 years. The current process is we need a financial plan for 26-27 and a 3-year strategy, a commissioning strategy for the next 3 years is the timescales that NHS nationally are asking for. And it's that 3-year one where we need to be getting into a more meaningful conversation. As ever, it's always up for grabs, in particular for turning around any financial challenges. But as ever, the financial challenges limit the capacity in which that can be made real. I'm giving you a bit of a politician's answer, but yeah.
Yeah, just I don't want to put more pressure on Angela and Sally, but at the end of the day, I think you guys have got real big opportunities here to really showcase what we can do in the sector. And I really look forward to, so if there's any support we can give you anywhere, just shout up. Just got one little question, and it's just a side question. Andrew and Sally, do you deliver from your organisation? Do you directly deliver services that you're talking about today alongside your infrastructure role? Are you delivery service providers as well?
Shall I go first? Because I think we do two slightly different things, don't we? So I would say no, we don't. We don't. We're focused on infrastructure. I suppose where there's a slight, there's a tiny blurring of that, and sometimes I've debates a little bit about this, that we do provide some link working or navigating arrangements. So our Healthy and Home model or our mental health navigators, we've got a number of projects where I would say that connection to the sector is a central role for CVS's. And we take that where there's a pot of money to invest in the groups that we're making referrals to. So it's a social prescribing model with a pot of investment for groups. So I think that's really the only thing that anybody might see as problematic that we're doing. And it's different, isn't it, in different places, because it depends on the sector and how well developed is it and your history and all of that kind of thing. But, you know, a central offer for groups and supporting groups and our advocacy stuff, and then that social prescribing and connecting function is one of the things we do.
Thank you.
Thanks, Sally. Angela?
Thanks for the question, David. It's good to see you. I know you've been in the system as long as I have, I think. Slightly different. Sefton CVS does deliver some services, but our focus, like Sally has said, is on link and signposting, say connector roles, social prescribing and others. However, our key advocacy is about getting resources into the sector. So if we form a lot of collaborations, I mean, I mentioned warm spaces, there's a sizable resource comes with that. So 40 organisations are delivering that whilst we are programme managing that, Dave, and doing the delivery and monitoring and evaluation impact. We've just negotiated with the council support around £400,000 worth of voluntary sector frontline investment into Southport recovery, particularly around health, youth services and so forth. And also through collaborations such as Living Well, we have a £1 million a year public health contract, but most of that is going into voluntary sector frontline delivery through Sefton Carers, through Sefton CAB, Feel Good Factory and others. So I think we emphasise in the system, and I'm sure Tracy may come in on this, is the importance of resource flow to frontline organisations, because my concern would be in the neighbourhood delivery model, if you just do business as usual, those organisations are already absolutely stretched and they need to have a resource flow that follows, whether it's specialist organisations, which I think is mentioned in the chat, but also neighbourhood organisations. So, you know, our advocacy is going to be around community hubs, community assets, use of the voluntary sector estate more effectively, and, you know, longer term investment. As Warren said, this year-to-year funding is it's why can't we invest, as people do, in infrastructure contracts of 5 to 10 years? They should be doing that in the voluntary sector too. So I hope that partly answers the question, Dave.
It does.
Thank you, everyone. There was a couple of other questions in the chat would be useful to I don't know if people want to put their hands up. There was a lot around funding and investment, which I know we've kind of tried to cover there, and I'll come back to that later on. One of the questions from, I think it was Gary Cliff, was who's put in 3 effectively. I think one was around how is the integrated neighbourhood team funded. I know that's kind of linked into stuff, but it'd be interesting to get a sense of how that building block is being invested in. Or have we covered that in that last question? I don't know if anybody wants to come out. Tracy.
Yeah, I could just highlight a little bit from a Sefton perspective. I suppose a few years ago, commissioners did invest in some key roles in what are our integrated care teams, which we're obviously building on now to really enhance them to become the full sort of integrated neighbourhood team approach. But at the core, those integrated care teams had some had a coordinator role funded via our community provider, and had some investment for some of those health and wellbeing trainer roles that I described earlier, and then other partners aligned key colleagues into those teams. So there was some additional investment historically to get those integrated care teams up and running, but the future, as sort of described in the chat, is really it's for partners to come together and share resources to ensure that neighbourhood teams come together in its ways of working. There is probably little additional investment flying around at the moment, certainly, but there's a lot of resource, held in those partners that need to come to the table around enhancing the next step around integrated neighbourhood working. So that's the conversation that's happening amongst partners now about what contributions each partner brings to the table to make that take it to the next level, really. I hope that's helpful.
Thank you, Tracy. The second part of Gary's first question was how much of a problem has data sharing been? I know we've talked through some of the tools like Cypher and the population health data management as being a big part of being able to understand who needs the additional support. But I'll ask you to come in there, Rachel Jones, Sefton, Rachel Jones.
Yeah, it's a good question and something that has been discussed in a lot of the meetings I've attended on neighbourhood health. And again, we've learned from our experiences elsewhere. So when Angela and Sally talked about those connector roles, a lot of those connectors are using other organisation systems. So they're using EMIS, which the local PCNs use. They're on Rio, which Merseyside use. They're using local authority social care systems and getting consent from the client, the patient, the person really whose data is being shared. So we're learning a bit from that, but having conversations about that wider share. And it's like anything, it's not always easy and simple, but we're all committed to making it happen. But certainly there's been a question about whose system do we use and which system do we use, and we're still having those conversations at the moment. So might be something to come and ask us again in 6, maybe 12 months, how we got through all of that. But that's certainly where we're up to at the moment, from my perspective.
Thank you, Rachel. I know, Rachel Franklin, you've put your hand up to answer that as well.
Yeah, thank you. Yeah, I suppose, I mean, data sharing has always been and continue. I'm a clinician by background, so I think it's always been and will continue to be a challenge, but not an insurmountable one. So certainly through the care communities work that we've been doing in St Helens, we've worked really hard on that data sharing in terms of, different organisations having kind of different levels of access to systems. We are looking at using the shared care record as a system that multiple partners can have access to. So certainly in St Helens, the shared care record has been around for many years. Earlier, back end of last year, I think it was migrated to a Cheshire and Merseyside kind of system so that it was opened out to other places across the system. And that kind of delayed some of the functionality within it. So within our care communities, we had started to test out using that shared care record as a means to, when our multi-agency teams meet to discuss a person's kind of needs, the idea was that you can document that on the shared care record within a specific tab and then build a care plan as part of that group discussion, and then partners can then go into the shared care record and update and amend that. So this was actually before the bids, so we were working on this in May and June of last year. So we're still kind of working that through in terms of that template. From an IT point of view, it didn't look like it had been built by clinicians, so it wasn't quite fit for purpose. So we're still progressing those conversations. And then equally as part of kind of data sharing and consent and that kind of thing in terms of people being discussed across multiple partners, we worked really closely and had a deep data protection impact assessment agreement drawn up. So for example, in our care communities, the last group of people we were discussing were the children and complex families, but actually the referrals into that were from a school. So it was around making sure that the person knew that the referral was coming from the school who had concerns about the child. But then when we were talking about the child, we'd be talking about the whole family. So we had kind of quite specific consent, and that consent form went through some parent and carer forums. So we were able to get the sense of people who might have been completing these forms. Does this make sense? Is it really clear what you are consenting for? So I think what we found through care communities, it's been a case of, doing some of the formal governance processes and structures, but actually having conversations with people about understanding what information is shared with who and why, and that's kind of helped some of that. Hope that helps.
Does absolutely. Thank you. Amina, you've got your hand up. Do you want to ask your question?
Yeah, thank you very much. Hi, my name's Amina Ismail. I work for the Liverpool School of Tropical Medicine on a project called Recite, and we actually work with Sefton CVS, are one of our partners, and we work with lots of other VCFSE organisations across the city region. And I just wanted to actually ask something around the data sharing point, because one of the challenges is in terms of that data flow, the system currently is built to share data from health organisations with other health systems partners, academia and others. But in terms of VCFSE, it's not built to share data with VCFSE partners or organisations, not the infrastructure bodies necessarily, because I know that they have systems in place, and because you've got those link workers, you have access to EMIS and other systems. But considering that there's a push for more community-led involvement in addressing health inequalities and this neighbourhood model, what plans are there, if any, to support and advocate for community stakeholders to have access to data? Sorry.
Thank you. Rachel Jones, Sefton CVS.
Yeah, you're right. It has been something we've worked through. I don't think there's a clear strategy or plan in terms of how that will be rolled out and considered. At the moment, it's being worked up. But I would say we have managed to get other voluntary sector organisations onto some of the NHS systems, particularly around the mental health projects. And again, like Rachel Franklin said, with varying levels of access appropriate to the work they're undertaking. So I don't think there's a definitive, this is how we're going to do it and how it'll be rolled out, but we have seen it happen in some sections, and hopefully we can build on that, will be built on further going forward. And that's been our experience in Sefton.
Can I just add one more thing? I think that would be really useful as a outcome of the work that you're doing, to show the examples of how you've been able to do this across the landscape. So
yeah, and if I can just say as well, from learning as well, it is not an easy thing to do. There's a lot of governance around it and robustness, rightly so, around the NHS's requirements to use their system. So that's something that organisations might want to be thinking about and preparing for, about how well placed they are to follow the audit for the NHS to get on those systems at the moment. And I'm sure we'll try and influence making that as simple as we can going forward for organisations. Thank you.
Thank you. I can't see any other hands up. I know there was a very deep question around, if I can just find it in the chat. I might go to Kirsty Roberts if you don't want to ask your question. Have any of the locality teams invested any time in organisational development, workforce development and culture aspect, which was touched on in certainly the presentations as part of building neighbourhood working? So is there any sense in which VCSE workforce, organisational development, culture has been a part, or may play a bigger part in the future of your working partnerships and models? It's a big question. I don't know if anybody wants to take that on. This is enough dealing with the day-to-day. Tracy.
I was just about to say, I think in terms of the OD aspect is really well made. It's really recognised that to be able to create the change that's required and to bring partners together in those neighbourhood teams, it's absolutely critical that sort of training and development, that OD piece happens. And to be honest, I suppose we've been talking about it for a number of years. We've had certain attempts at it, but with the neighbourhood pioneer approach now and a sort of refreshing of our ambition in Sefton, we're currently having those conversations with all our partners about what OD resource have we got in Sefton, how can we use that, how can we bring that team together to help us with some of that, that team building. It's really, really important. So just that aspect of the question, I just really wanted to emphasise, it's absolutely critical. Thank you.
Thanks, Tracy.
Thank you, Tracy. It was. I know Sally mentioned the health equity programme was being an important part of the culture change, but Mark Gabbay's put his hand up and wants to ask a question.
It was more to make a point. Has anybody, I'm sorry, I was in other meetings, so I've only come into this fairly late, apologies. Has anybody talked about the applied research collaboration and what we're planning to do in the new ARC from next April? And if not, it might be helpful if I just did a couple of sentences.
Happy to, Mark, if it's brief.
Sorry?
Absolutely, Mark, if you would.
Okay, so the applied research collaboration, for those of you who aren't familiar with it, is an National Institute for Health and Care Research funded infrastructure for research and getting research into practice through what's called implementation. And it's about applied health and social care research. And we cover the northwest coast, so that is all of Cheshire and Mersey. So the embargo has now been lifted since the budget, so we can now confirm that the ARC Northwest Coast has been refunded from April 2026 for a further 5 years in the first instance. And we are changing the way that slightly changing the way that we want to bring in the excellent support from VCFSEs into this programme of work. Rather than doing something separate from the integrated care systems, we want to work alongside the integrated care systems, because I'm aware that many of you already have lots of relationships through that system and infrastructure. So what we want to do is to tap into that in the north of Patch and south of the Patch and across the two. So there will be lots of things happening. The ARC Fests are going to be happening 3 times a year. We definitely do want to work with VCFSEs. We have got a big inclusion programme. Our focus remains health inequalities. So we have a big equity programme and focus as well. And co-production remains at the heart of what we do. So rest assured, we're still very keen to work with VCFSEs. And what that will be either directly or as a way of working with communities in partnership with the local VCFSEs. And there will be small amounts of funding to support sort of pump priming work and things like that. It's going to be, so Coron is changing, but it's not going, just to reassure you. It'll be delivered in a slightly different way, but we still very much want to work with communities, especially those communities that don't usually get listened to in research activities.
Thank you, Mark. I'd be happy to pick up how we could help share the news about the model of working, and congratulations on the new investment, well deserved. I know it's not been it's been a big piece of work that you've led on, Mark. So thank you.
Certainly has. It's still ongoing.
Yeah, we'll pick up that and look to support wider VCFSE engagement in the new ARC delivery model with you if you're happy to do that, Mark. But thank you for the quick update. We've come to the end of this. I've on the agenda it says summary and final thoughts, which always feels a little bit like a shortcut way of undermining all the detail that we've heard about today. I think the key lessons for me is the importance of a partnership model as a whole, not just kind of integrated neighbourhood working in terms of teams, but thinking about how that works, how that links to people and communities, and the importance of voluntary and community faith social enterprise sector leadership and insight. Really impressed with the tool from Sefton CVS around community insight and intelligence, and about the possibilities of whether that could be scaled up. But I'd be interested in other places and their local pieces of work that they're doing. I think we had a really nice summary in, I think it was the penultimate slide from Rachel Jones and Sefton around top tips for influencing neighbourhood health. I thought that was really important, and that message around building on what is already working, thinking through current assets, current resources, and thinking through how that's supported. I really liked the focus and on making a difference for people and communities that Tracy Jeff shared in terms of, I think it was Lincolnshire, the piece of work, but that really translates not only the engagement piece with communities, but the focus on delivery and need and partnership, rather than just creating the right structures, which I thought was really important. So that message around co-design and co-delivery with the VCFSE sector seemed a really important key message for me. I thought the last point was around changing culture around partnership and delivery of the VCFSE sector. It's sometimes hard to see where the sector fits into some things like national NHS guidance, but the importance is never lost, certainly in the places like Sefton and St Helens, and hopefully broader in Cheshire and Merseyside. So I thought that was really important. So thank you very much to Tracy Jeffs, Angela White, Rachel Jones, Rachel Franklin, and Sally Yeaman for all you've done and shared today. We'll look to pick up further pieces of messaging and sharing of what's going on. I think one of the areas we were looking at potentially for a next webinar would be on the role of children and young people, VCFSE organisations in neighbourhood health. So we'll pick up on that, and I'll talk to Mark around some of the messaging around the ARC and the programme of work that they're embarking on for the next 5 years as well. So thank you very much, everybody, for coming. If there's any further questions, please do send them in, and we'll ask the experts in the room on the ground and in the front line for their answers. So thank you very much, everybody. There's another session in January, on January the 14th, around the voluntary sector role with combined authorities. We will soon have full coverage across the northwest and the north of England of strategic authorities from the new year. So we thought we'd best make sure we were sharing learning around that as well. Thank you, everyone. Thank you to our speakers in particular.
Thank you.
Merry Christmas.
Bye-bye.
Merry
Bye.
Christmas. Thank you.
Thank you.